I'm very honored for the invitation. And today I will talk about the novel Expandable Cryoballoon Ablation for Atrial Fibrillation. These are my disclosures. So as all of us know, cryoballoon pulmonary vein isolation, PV isolation, is a well-established method in catheter ablation of AFib. As you can see, pulmonary vein can be isolated by a single freezing, usually 3 to 4 minutes of freezing. In Japan, since 2014, already 120,000 patients underwent cryoballoon ablation, mainly using Arctic front cryoballoon, recently POLARx cryoballoon. In general, the cryoballoon procedure is very short, less than 1 hour, and the learning curve is relatively short as compared to radiofrequency ablation, and the low rate of lethal complication. Especially in Japan, we have no cases with atrioesophageal fistula up to now, and in my experience, I have never seen the cardiac tamponade during 10 years, during the cryoballoon ablation for 10 years. However, the concerns of cryoballoon ablation are the relatively high incidence of phrenic nerve injury. During Arctic front advance cryoballoon procedure, the reported incidence of phrenic nerve injury is approximately 4 to 11%. The limited choices in the balloon size, that is a fixed 28 mm balloon. Just recently, POLARx Fit cryoballoon has become available in Japan. The POLARx Fit is the only cryoballoon with a dual diameter balloon size in one catheter, offering elasticity to accommodate surfaces ranging from 28 to 31 mm. The choice between 28 and 31 mm diameter in a single device has enabled a vein occlusion at a more anterior balloon positioning, which might reduce the risk of phrenic nerve injury and PV stenosis, and also might create larger isolation area. So this is an example of voltage mapping after cryoballoon PV isolation using a 31 mm diameter balloon. As you can see, the isolation area seems to be large. Up to now, the data of a fit balloon is very limited, so today I will pick up 2 literatures. The first one is Dr. Fromeyer reported the feasibility and the efficacy of a fit cryoballoon for atrial fibrillation. This study presented the acute procedure results only. It included 12 consecutive patients with mainly paroxysmal AFib patients and persistent AFib. And the PV isolation was completed in all patients successfully. If you look at the balloon size, in 55% of applications, the 31 mm diameter was employed, while in the remaining 45% of the applications, the 28 mm diameter was employed. So second one is frozen AFib trial, which was an international multi-center, open-label, prospective single-arm study conducted by Dr. Ellen Bogan and Dr. Su. This study included over 300 paroxysmal AFib patients treated with POLARx balloon. In addition, included 50 paroxysmal AFib patients treated with POLARx Fit balloon. I will focus on the latter population. So this is a voltage map after cryoballoon PV isolation when using 28 mm balloon and 31 mm balloon. As you can see, the isolation area was significantly larger when using 31 mm cryoballoon. So this table shows the study results. As you can see, 2/3 of pulmonary veins were isolated by 31 mm balloon. If we look at the balloon temperature during the freezing, you can see the comparable balloon temperature between 28 and 31 millimeter balloon. Transient phrenic nerve injury occurred in one patient. The freedom from atrial fibrillation was 84% during the 1-year follow-up, and redo procedures were performed in 4 patients. So I will show you our study results. So this is the early results from a multi-center ablation registry. So we included 140 patients, including 86 paroxysmal AFib patients treated with a fit Cryoballoon. We compared the biophysical parameters between the 28 and the 31 millimeter Cryoballoon in each pulmonary vein. It should be noted that physicians choose the balloon size during the procedure by operator's preference. Overall, the biophysical parameters are comparable between the 28 and the 31 millimeter Cryoballoon. However, there are some differences. In left superior pulmonary vein, the capability of PV potential recording was significantly higher when using a 31 millimeter balloon. And the balloon temperature drop was significantly faster when using a 28 millimeter balloon. And interestingly, in left inferior pulmonary vein, esophageal temperature reached 15 degrees Celsius in 43% of the patients when using the 31 millimeter balloon, which was significantly higher than that for the 28 millimeter balloon, indicating presumably because the 31 millimeter Cryoballoon positioned more proximal position, which was close to the esophagus. We also investigated the distribution of atrial lesions with a novel size-adjustable Cryoballoon for PV isolation. So this study included 22 patients, including 9 non-paroxysmal AFib patients. We created the high-density voltage mapping after Cryoballoon PV isolation, and the distance between the PV office and the isolated area edge was evaluated in 8 segments for each left and right PV. So this is the study results. The blue area indicate the isolation area. As you can see, the isolation area was significantly greater at posterior side of pulmonary veins rather than the anterior side of pulmonary veins. Among 22 patients, unintentionally, roof line was created in 2 patients, and the left atrial posterior wall was isolated in 1 patient. And even in patients with non-paroxysmal AFib, the isolation area was clearly large. And we have no cases with non-isolated carina area. So these data indicate that the size-adjustable Cryoballoon, fit balloon, achieved a wide antral PVI even in non-paroxysmal AFib patients. So this is our study results, real-world data of size-adjustable Cryoballoon ablation. So in this study, we included 535 consecutive AFib patients treated with fit balloon in 5 Japanese centers. A single freeze cycle of 3 to 4 minutes was applied, and priority was given to the 31 millimeter balloon. However, the balloon was switched to a 28 millimeter balloon if a vein occlusion was not capable or failed to isolate the vein. In order to avoid phrenic nerve injury, as usual, diaphragmatic electromyography was monitored. The minimal Cryoballoon cutoff was set at -70 degrees Celsius. So this slide shows the patient characteristics of the study. As you can see, the mean age was 67 years old, and 35% of the patient had non-paroxysmal AFib, persistent AFib. The esophageal temperature was monitored in 87% of the patients. Among 2,000 PVs, 79% of PVs were successfully isolated by the cryoballoons. 62% and 35% of PVs were isolated by a 31 and 28 mm balloon respectively. A single-shot isolation was achieved in 83% of PVs. PV potential monitoring was capable in 74% of PVs. The total number of applications was 5, and the total application time was 840 seconds per patient. I think these numbers seem to be relatively small. The total procedure time was 1 hour and a half, and the total fluoroscopy time was 22 minutes. So these numbers included the time beyond ablation, beyond the PV isolation. So this slide shows the cryoballoon parameters in each pulmonary vein. If we look at the one-shot isolation rate, it was highest for the left inferior pulmonary veins and lowest for left superior PVs, presumably because the presence of inter-PV connections between left superior and left inferior PV. Upper PVs were more likely to be isolated by a 31 mm cryoballoon, mostly 80%, and as compared to the lower PVs, approximately 50%. The nadir balloon temperature was lowest for right superior PVs and highest for left inferior PVs. The TTI monitoring capability was highest for left superior PVs, and the TTI was longest for left superior PVs. As you know, generally the PV musculature is longest in left superior PV. The nadir balloon temperature and the TTI monitoring capability were higher with a 31 mm than the 28 mm balloon, while the TTI was similar between the 31 and the 28 mm balloon for all 4 PVs, indicating that physicians properly choose the balloon size for each individual PV. We also compared the patient characteristics and the procedure parameters in paroxysmal and non-paroxysmal AFib patients. Non-paroxysmal AFib patients had significantly larger left atrium and lower left ventricular ejection fraction than paroxysmal AFib patients. One-shot isolation and TTI monitoring capability was significantly higher, and the touch-up rate was lower in paroxysmal than non-paroxysmal AFib patients. PVI was achieved significantly more with a 31 mm than 28 mm balloon in patients with paroxysmal than non-paroxysmal AFib. If you look at the detailed parameters, TTI and the total application duration were significantly shorter in paroxysmal AFib than in non-paroxysmal AFib patients. However, nadir balloon temperature was similar. So these data indicate that even using fit cryoballoon, size-adjustable cryoballoon, probably the best indication of cryoballoon ablation is paroxysmal AFib rather than the non-paroxysmal AFib. So this slide shows the procedure-related complications. Phrenic nerve injury occurred in 6.4% of the patients, including 4.7% during right superior PV ablation and 1.7% during right inferior PV ablation. Phrenic nerve injury occurred during application with a 31 mm balloon in 25 patients and 28 mm balloon in 8 patients. So this is a bit surprising for me. The phrenic nerve injury could occur even using 31 mm cryoballoon. The time to the phrenic nerve injury occurrence was approximately 2 minutes, and female and the presence of structural heart disease were associated with the occurrence of phrenic nerve injury. However, there were no significant difference in the LA size, AFib type, or freezing speed during the procedure, suggesting that it is not easy to predict the occurrence of phrenic nerve injury during the procedure. Although the follow-up period was short, the 2/3 of the phrenic nerve injury recovered during the follow-up period. So this slide shows the freedom from any atrial arrhythmias after a single procedure. The follow-up period was relatively short. The freedom from recurrent atrial arrhythmia at 6 months was 85%. And the Cox regression analysis revealed that paroxysmal AFib was the sole significant factor associated with the freedom from atrial arrhythmias. And the atrial arrhythmia freedom was significantly higher in patients with paroxysmal AFib than in those with non-paroxysmal AFib. And during the short follow-up period, 15 patients underwent redo procedure at 6 months after the initial procedure. And the PVA durability during the redo procedure was 74% per PV and 53% per patient. I think these numbers seems to be reasonable and sufficiently high. So in conclusions, our real-world registry data outcome demonstrated a consistent high procedure efficacy and safety of the novel size adjustable cryoballoon. Thank you for your attention.